Great. I'm glad that folks are able to join us tonight for the second session with the North Dakota EHDI program. We're really excited to have this partnership together and work on providing some education for the public on newborn hearing screenings and the North Dakota EHDI program. So Tori Allen is going to lead us through when she's going to introduce our guest speaker for tonight. So go ahead, Tori.
Hi, everybody. Like Denise said, I'm Tori Allen. I'm with the North Dakota EHDI as the family support liaison. I do have a little one of my, not a little one anymore, kiddo that's deaf, hard of hearing. She's 19 now, and so this is kind of where I get all of my momentum from. But I am here to introduce Trisha, and I'm sorry, I'm not going to say your last name because I probably will not say it correctly. So, and she is a clinical audiologist and a pediatric specialist in Minot, I believe. Is that right?
Yes.
And so she's going to walk through some audiology 101 with us tonight. So we're super excited to have her here, and I will let you take over.
Wonderful. Thank you. Thank you, Tori, for inviting me to be a participant in this group. I think it's great that we can offer some extra education to our families. I'm going to talk a little bit about testing in our youngest babies, and I just thought I'd throw a couple pictures of my own two kiddos on the front here. They are obviously babies in this picture. They're no longer, but I thought these were good pictures too, just to kind of set the stage for when we are doing our testing. This is like the ideal state that we want our babies to be in, kind of calm, relaxed, sleeping if needed. Sleeping is preferred, but these two pictures kind of highlight perfect ideal babies for testing. Next. And you can, yeah, perfect. So a little bit about me. Yep, Tori kind of nailed it. I'm a pediatric audiologist at Trinity Health in Minot. I've been there since 2012 and have loved my time and my experiences. I spent most of my graduate work training in pediatric facilities and primarily in pediatric hospital settings. I have clinical interests in a lot of things, but currently my main clinical interests are in pediatrics, auditory processing disorder, which we could spend a whole nother slide or whole nother talk on, cochlear implants, hearing aids, best practices, making sure that we're doing everything we can to advocate for not only the kids we see at Trinity, but kind of as a state. One of my primary interests has been trying to get more of the audiologists in our state together and just kind of team up and see what is working well in places and how we can continue to help kids across the state, just improving the care everywhere. Next. So first and foremost, thank you for taking the time out of your evenings or your days, if you're watching this later, to learn more about this testing. I want to, welcome everybody and hope that you can learn a few things about how we test babies. If anybody's on and has questions, please just jump in and ask. That goes for you guys too, Tori and Deneen or anybody else. I want this to be worthwhile, informal, and educational for everybody that's on the call. Or if you're watching it later, I have my contact information at the end, and you can feel free to reach out to me anytime. I'm always happy to answer questions to anybody if things come up. So I'm going to kind of plan to cover what ABR testing is, why it's important, how we complete our evaluations, and what happens after we confirm hearing levels. I didn't really know like the target audience, if people watching this were going to be kind of maybe they have an appointment scheduled and it's coming up, or if more people had already kind of been through the journey and have already been through maybe the ABR testing and are in that next phase, but we'll kind of cover everything from start to finish. Next. So I think I always try to start my talks from my perspective as the audiologist. My role in this entire picture as the audiologist is to assess, diagnose, treat, and manage hearing differences in children. And I always try to kind of acknowledge my bias toward hearing loss management and treatment with a main focus on spoken language and listening as the primary means of communication. That being said, I do my absolute best to try to support and provide information across the range of communication options and modalities, and do everything I can to facilitate whatever the family has chosen down the road for communication means. But in order to get to that point where we have choices, we really need to make sure that we are identifying hearing differences early on, and managing them, and really doing everything we can to educate families about what the different options are. So obviously in our world, the earlier we find things and identify hearing levels, the better the outcomes will be in the long run. So the EHDI program, and many other academic groups and researchers across the world have spent years researching outcomes and have repeatedly found that children have the best language, academic, social, and emotional outcomes when we use the 1-3-6 models. So we want to screen hearing levels by 1 month, we diagnose and confirm hearing levels by 3 months, and we provide the proper interventions by 6 months. And interventions are going to look different for each child and family, but we want to do our best to make sure we're providing access to those, and support our families in following through, not just starting them, but making sure we're following through on those interventions by 6 months and forward, obviously. In that model, we're going to do everything we can to minimize the chances for language delays. And also that we're kind of working in harmony with our baby's natural development patterns, and doing everything we can not to get to a point of delay. Next. So early detection of any type of sensory difference is critical. I like this slide with kind of the blurred out, differences between like what maybe typical hearing looks like. I think a lot of people like to compare hearing loss to vision loss, but it's a little bit different, and you can kind of see those visual differences. Early detection of hearing differences, again, allows parents the most time and the most informed decision making for their futures. So babies' brains are in critical periods of development where literally billions of new connections are being formed each and every day. Neural highways and neural networks and webs that are stimulated repeatedly are strengthened and maintained. Neural highways that are not are kind of pruned out or lost. And even in the earliest years of life, if our brains and our bodies are not using something, we are losing functions. And so this is especially true for the hearing tracts and highways from the ear into the brain and throughout the auditory centers in the brain itself. So we can prevent delays, we can stimulate all of the kind of the connections and highways that we can when we're finding hearing differences early, and we're providing the right tools, team members, and technologies. And that's, again, whether it's spoken language and listening, sign language, visual language, whatever, any sort of combination in between. And then I also like to just throw it out there that, if a family is pursuing sign language, that also we're checking baby's vision and making sure that baby can see well and has visual access to the language that we're going to be using with that child. Next. So the next 2 slides are a little busy. There's a lot of words. You can certainly feel free to read through all the words if you want, but the 2 slides are showing some of the main highlights from a really, really big study called the Outcomes for Children with Hearing Loss. They've got a whole webpage and just a ton of really good information. The researchers recruited kind of a multidisciplinary team of professionals from the University of Iowa, Boys Town, University of North Carolina, lots of different people in different places of the country. They had audiologists, speech pathologists, psychologists, linguistics, all these different people, and really focused on examining the impact of newborn hearing screening, early intervention, and advances in hearing technology on a wide range of outcomes. And so just the couple of places that I wanted to highlight, and key findings from the study were what we've already talked about. I'm not just saying it, like the research has shown that earlier identification is going to provide kids and families with the best outcomes. The earlier we find it, the better. That, along with consistent use and parents just continually and constantly talking and kind of just bombarding your babies with words and language, doing, again, everything we can to just keep stimulating all those little pathways up and into the brain and in the brain. That's how we build vocabulary and, again, strengthen all of those different highways and build these vocabulary webs and maps. Earlier fitting is shown, if we're diagnosing a hearing loss and, parents want spoken language and listening, the sooner we fit hearing aids, just the better it's going to be for baby's brain development. And of course, we'll still see good outcomes and benefits from kids later. It's just, we're going to see the least amount of delays if we are fitting earlier. And of course, the more severe the hearing difference is, or the hearing loss is, the greater risk there is for delays. And even with the absolute best technology out there right now, we do not fix or cure anything about baby's hearing system with a hearing device. So I think of hearing loss more than anything as like a chronic health condition that's going to be with baby for the rest of baby's life, the rest of your life. And we want to, when we're using tools like hearing aids or cochlear implants, they're a tool, they're not a fix. And so the more severe hearing loss there is, the less kind of structures we have in that inner ear to use and stimulate. And the first couple of years of life are really when we're kind of laying just the groundwork and the building blocks and the foundation for baby's brain and baby's brain development for the rest of their life. So it's a responsibility that I don't take lightly. It's one of the most important things that we can do as pediatric audiologists is do our part in identifying things early. And early intervention is the key to success in most of these, in any chronic health condition. Next. And so again, it's kind of wordy, just more on that study. And I think, again, just making sure that we're wearing hearing aids. We want to make sure that babies are wearing hearing aids 10+ hours a day if we get to that point. And I'm sorry, I'm kind of jumping ahead with the study information. I didn't even talk about how we got there yet, but just stressing early intervention. Next. So now that we kind of understand why we want to measure hearing levels early and the importance of completing hearing evaluations before that 3 months of age mark, I want to kind of get into how we go about the testing. And I thought this video clip would just be a little bit more interesting and engaging way to learn about how sound is traveling through the entire pathway and into the brain. So we'll watch this short little video clip together here. It's about 1.5 minutes. Oh, is there no sound?
Is it captioned?
There should be sound. It should be talking.
I can hear it, so let me see.
It's like playing music right now, or it should be. I don't hear
Have
it.
you ever wondered how sounds make their way from the source all the way to your brain? Take a trumpet, for instance. When it's played, it makes sound waves in the air. The outer ear catches the waves, which then travel through a narrow passageway called the ear canal. The sound waves reach the eardrum, which is a membrane roughly half the size of a dime. They make the eardrum vibrate, which in turn vibrates 3 tiny bones called the malleus, incus, and stapes. These bones amplify or increase the sound vibrations and send them to the cochlea. The cochlea is shaped like a snail and is the size of a garden pea. It is filled with fluid, and the sound vibrations make this fluid ripple, which creates waves. Hair-like structures called stereocilia sit on top of hair cells and are grouped together as hair cell bundles inside the cochlea. The hair cells inside the cochlea ride these waves, and the hair bundles are moved. The hair bundle on top of the hair cell turns these movements into electrical signals. As the hair bundles are moved, ions rush into the top of the hair cells, causing the release of chemicals at the bottom of the hair cells. The chemicals bind to the auditory nerve cells and create an electrical signal, which travels along the auditory nerve to the brain. Different hair cells respond to different frequencies of sound. The hair cells at the base of the cochlea detect higher-pitched sounds, such as a piccolo or flute. The hair cells toward the top of the spiral detect progressively lower-pitched sounds, such as a trumpet or trombone. At the very top or apex of the spiral, the hair cells detect the lowest-pitched sounds, such as a tuba. The auditory nerve carries the electrical signal to the brain, which interprets the messages as sounds that we recognize and understand.
All right, next. And so the video kind of left off right at the perfect time. The auditory brainstem response testing we do is actually watching how the hearing nerve is responding and reacting to sound as it's traveling along the path from the ear, the cochlea, on up into the brain. So this testing does not require any sort of response from babies, since the hearing nerve is constantly analyzing and responding to sound even when we're sleeping. The testing is done in real time, and we can and can be completed most accurately and quickly if baby is sleeping. So we play sounds through tiny little baby earphones and use little stickers called electrodes to record the hearing nerve's response, or really just the electrical activity the hearing nerve is generating at different spots to those sounds. We start at louder volume levels and kind of work down, and we just watch for a strong response from the nerve when we are playing a louder sound, and then slowly turn it down until the electrical activity goes away. And if I'm playing a sound and the nerve isn't reacting, I know that sound's not getting carried through up and into the brain. So I kind of think about this, or sometimes I explain it to parents like a train on a one-way trip, maybe from Minot over to Fargo or something, where we're looking at kind of not only the response from the different centers or the different hubs, but also the timing. We want to make sure that, when I'm playing a sound, that it's getting through and into the brainstem in a certain amount of time. There's a lot of different information, not only in the actual response we see, but in the timing that it takes to get there. The testing we do is painless and safe. We've been using this testing for more than 40 years in the field. It's reliable and accurate, like I said, even when babies are sleeping. Next. So benefits of this testing really are, this is the most objective way that we can measure, and really the only way that we can measure hearing levels and accurately identify hearing levels. We can obviously, play a sound or clap or, make a noise and see if baby's responding to that, but that does not give us the information we need to know about how well they're hearing at 3 weeks old or 4 months old. This testing definitely gives us the accurate information in a pretty quick test. And it's really essential for determining what the most appropriate intervention and management options are. Again, just early detection, because we can test this at, the earliest I've ever tested a baby was, I want to say 4 days old. I had went into the up into the hospital. Baby was in the NICU, did testing right in the NICU. So our equipment is mobile. We can kind of bring it anywhere. I used to go out to Williston. I would do testing out in our satellite clinic out there. It's portable. We can bring it anywhere. I would love to have a mobile audiology unit at some point in my career. I think that would be fabulous if we could actually go to families' homes, or have, families come to us in the community that they live in, and so they're not having to drive for so long to get to us. But anyway, non-invasive and safe for patients at any ages. So, most of this is kind of geared toward newborns and, again, before around 3 months or before 6 months for sure. But we use this testing on older kids too. So some of our kiddos that are coming through clinic, with concerns for hearing loss, if we're not able to test them, or, if they're not able to participate in testing, we can, we can use this as a means if possible. As long as kids can sit somewhat still, I try. I've diagnosed 18-month-olds while they slept in a pack and play. I've had parents bring in pack and plays or whatever they want to try. I'm willing to work with families and just try to figure out what might make baby comfortable enough to fall asleep for an hour or two in my office. It doesn't require sedation in our very youngest children. Again, sometimes in our older kids, if they're 2, 3, 4, and we need to identify hearing levels and we're not able to get them to participate in testing, we will sedate and go into the operating room. But it's not as common for me to jump right into that. We can differentiate the type of hearing loss to know if this is something that's permanent versus just temporary. So conductive hearing loss, we think of that as temporary. That's going to be like if you have an ear infection and there's fluid blocking the hearing system, versus a more permanent type of hearing loss, which is what we call sensory neural. We can use it, it's an objective measure, so it's nice if you have a baseline, you can always come back to that later and compare one test to another, and kind of monitor the auditory nerve function over time. Some of our kids have different types of neuropathy or demyelinating diseases that will change the nerve function over time, and you can see it happening in the ABR sooner than you might see it in other places. So there's lots of different uses. It's gold standard for diagnosing and confirming what we call auditory neuropathy or auditory neuropathy spectrum disorder, whatever we want to call it. So again, it's easy for, I don't want to say easy for everybody. It's easy. It's something I enjoy doing and I've done for years. So it comes somewhat easy to me. Accurate, reliable, safe, non-invasive, and gives us the information we need quickly. Go back one to the limitations. So I think limitations for me would just be that these tests are very highly accurate. They're not always perfect. We're not really assessing the child's full hearing system. We're kind of we're assessing the electrical activity along a nerve from the ear to the brain. So we're not really up in the brain and we're not monitoring or watching the way the baby is reacting to sounds. So it's kind of like a one-way train again. And when the babies get a little bit older, like 6 months, 4 to 6 months old, we'll start to actually test the entire system and have the babies respond and react and play with us. So it's not exactly the same as doing a behavioral hearing test, but it's the best we can do when they're less than 4 months old. Some types of tests or some types of hearing loss aren't easily detected or seen on an ABR if we're only using, like, there's different sounds we can play, and some audiologists are really comfortable using what we call a click. And if we're only using a click, we might miss certain types of hearing loss because they just won't show up with that particular stimulus. So it's really just important to test a variety of different pitches. Think about a piano, each key on the piano is different. We want to test the low and the mid and the high and make sure we're sampling different sounds along the spectrum to determine how baby is hearing all of the sounds, not just, one. And then hearing changes can happen anytime for lots of different reasons. So we might have a normal ABR test in month 1, but then hearing loss could change, or hearing loss could progress or develop. And maybe by like 14 months, there's a hearing loss. And so we obviously wouldn't have detected it at birth. So I think it's just really important that families are aware of auditory developmental milestones, not just speech speech milestones and gross motor milestones, but that we're also providing education about auditory milestones, and especially if there are any risk factors for hearing loss that we're, following up, we're monitoring, or at least providing information about what those auditory milestones are. Next. So I just took a couple pictures of the testing room that we have. It's not, I hope parents don't think our rooms are too scary. We have to, obviously I work in a hospital, so we have to consider infection control and things, but we tried to make our space as comfortable for parents and families as possible. Kind of in that upper left-hand corner of the picture there with the laptop, The laptop is the testing equipment. I've got it set up right next to that bigger kind of somewhat comfortable chair. The chair can recline for mom or dad to hold baby while we're doing the testing if they want to. We've got a bunch of extra chairs in the room for other family members or, other team members. I have other providers come in once in a while and support the family during the testing we're doing, or siblings or whatever. We've got a little cart with just a bunch of stuff for babies. I remember forgetting stuff all the time for my babies. So I just try to be thoughtful of, things that we might need. If something was forgot, we've got a whole little cart of stuff. I think that's pretty much it on there. Go ahead next. And so I just kind of want to talk a little about how we like prep the babies and, what is actually happening or how we set up the equipment. So we always want to clean off the skin where we're going to put the stickers and where the electrodes. So I think this is the part usually, I talk a lot at the screening appointment about prepping for this ABR test. And I'm always like, make sure baby is really tired and try to get baby asleep before we do the testing. So then they come in and they did all the things right and baby is sleeping. And then we have to prepare their skin and we use a little scrubby pad and then baby wakes up while we're scrubbing their skin. So that is never fun. But anyway, we just clean the spots off where the stickers go. There's different type of wires. The two different pictures show just two different types of wires. So some like snap on to the sticker, some clip on to the sticker. There's nothing wrong with one versus the other. So you might see, different types of equipment or leads, and that's just fine. We can place the electrodes, the stickers in different places too. So some people will use forehead, like the top baby's got two stickers, two electrodes up on the top. So they're using a 2-channel test. Baby in the bottom picture has just got the one. So they're using a 1-channel test. Nothing wrong with either one. I go back and forth just kind of depending on what I'm looking for, what I need. How you were trained, what you're comfortable with. There's nothing wrong with one method versus the other. Both of these babies have the stickers behind their ears on the mastoid, which is very common. But one thing I don't like about putting them there is, like, especially if baby's got the nook in the bottom picture. So if they're sucking on the nook, that muscle is just constantly moving and activating. And so if we've got stickers on the muscle, we're just measuring all this extra movement from them sucking or eating or whatever they're doing. So I try to get them up on the lobes if we can, just to eliminate some of that muscle artifact. No right or wrong, just whatever's going to get us the most accurate measures the most quickly. And then also we use the little baby headphones that are in the ear, obviously. So both of the babies have the insert earphones in. That's what's going to play the sound in, just like we watched in the video. So the sound will go through the headphone, and then we're using the stickers to record that hearing nerve response to the sound as it's going up to the brainstem and into the brain. Okay, next. So once we get everything set up on the baby and we're connected to the computer, we wait until baby is calm enough that there's not a lot of muscle movement, like I was just talking about in artifact. The more the baby is moving, the harder it is to see the tiny little hearing response compared to that really big muscle movement and muscle response. So I'll usually start just playing the sound and kind of watch what we're monitoring. We can see the muscle activity. So I'm going to start playing the sound and then just kind of watch what happens. Usually the baby, like, if we scrubbed and everything, got them ready and we put the sound in their ear, I'm usually kind of starting that sound at a little bit louder volume. So they're kind of moving around a little bit, and then they'll just settle in and fall asleep. And as soon as they're calm enough, we start the testing. I've gotten really good over the years at kind of anticipating when baby might move or start sucking, and you can just pause the recording for a second until they calm down again, and just keep doing that until we get enough of a response that we can generate, or that we can see a good hearing response. And then again, this slide is just kind of highlighting that we are looking for the different electrical activity from these different hubs along the process, along the hearing nerve. So we're looking at the cochlear nerve or the hearing nerve's response, and then the cochlear nucleus, the superior olivary complex, lateral lemniscus, inferior just all these little processing centers along the nerve. And really what we're doing is we're monitoring the last wave 5. So I'm going to show you here on the next slide, actually. So go ahead and next. I wanted to put what like a normal response is. I don't know how many parents are people actually see the tracings. I usually have my computer set up so parents can see what we're doing. And I'll kind of, if they want, if I'm gauging that they want to watch and want to be involved, I'm trying to explain what we're doing while we're doing the testing. So the kind of the top on the left side of the screen there, the yellow tracing up in the left corner, that's the left ear. The left ear is blue, the right ear is red. But that yellow tracing is just showing a really strong typical response. We've got these big, a lot of electrical activities happening, you know, in these different processing centers. So you see these nice peaks and valleys, these really big responses. And what happens is in each tracing, so like the top to the second, third, and the fourth, each of those tracings, we're just turning the volume down a little bit each time. And we're tracking that wave 5 movement down. So the yellow one is a pretty high level. It's like an 80 decibel sound. We always start at a high level, so we know we're watching the hearing nerve response. We want to make sure it's replicable, that it's accurate. And then you just turn that response, or you turn the stimulus down, the volume down. And so by the time we get down to that last tracing, it's at about 20. So, I mean, just think about like your volume on your TV. If you're at 80, you know, and you turn it down to 20, so the difference in the volume, the response is going to get smaller as we turn the volume down. And then both of these, you know, that graph, left ear and right ear are both normal. And then the next one over is normal as well. When I see this, it's like, oh, easy. You know, if you have a really clear, very like reactive nerve like this, you can pretty much right away, I'm guessing, okay, we're going to be pretty normal for certain frequencies. And I just kind of breathe a sigh of relief when we see this. Okay, next. And then I just wanted to kind of highlight or contrast that with what we would consider as like an atypical response, or when we're confirming, you know, that there's a hearing loss. So now kind of the same idea. We've got the same graphs essentially. Starting on that left side, we're actually starting at 95 decibels this time. So our starting point is, it varies. I usually start at 80. If it's not a very strong response, which is the second tracing on this graph in particular, it didn't look like the last slide. And so if I see this right away, I'm thinking, okay, we're probably going to have something going on here. And I want to go up and I want to make it a little bit louder and just make sure I see the response is there. And then I would go back down again and just go down until that response goes away. So in this left-hand side of the graph, we've got the first tracing is up at 95, super loud, goes to 85, goes to 75. And at 75, that response is, you know, you can just see it, it's getting a little smaller. And then that fourth tracing down, that response is going away. And so we know we're playing a pretty loud sound in. Again, think TV volume up at 70, and that electrical activity in the nerve is pretty small, pretty minimal. So if I see this, you know, we know we're going to have a hearing loss based on the way it looks and where that electrical activity goes away. And so again, that's the left ear, right ear on the other side. And then just another example over there on the other side in the red, it's 80, 70, 60. So again, this particular kid or patient would have hearing loss in that right ear. Next. And not that, again, you especially parents, like, you don't need to know what the waves mean or what they look like for any, you know, I mean, it's good information if you are interested in that. But it's nothing that, you know, like this slide, you definitely don't need to know all of this. It's just something that I wanted to share, that the way the waves look also gives us information about what we're seeing and what's going on and the integrity of the hearing nerve. So we can differentiate different types of hearing differences. And just by the way they look and the timing maybe that it's taking to get through the system. If we think about maybe right back behind the eardrum, there's a bunch of fluid blocking sound. So if you think about like listening underwater, everything is just kind of muffled and delayed and echoey and weird. So if we have a kid with fluid behind the eardrum, the sound is going to take longer to travel through the eardrum and travel through the chain. And so a kid with middle ear fluid, the timing is going to be delayed. So their response is still going to be there, but it's going to be shifted out and it's going to take longer to get through the system. So we're looking at a lot of stuff behind the scenes as we're doing this testing. And so, I was saying that I like to talk during the test and I like to be, showing families what I'm doing. But that is certainly not every clinician, because there's a lot of stuff that we're trying to monitor, make sure we're being accurate. And, we might be thinking a lot about what we're seeing. And so some clinicians might not talk at all, and that's not uncommon either. So just wanted to highlight that. Okay, next. So once we've kind of went through, I usually try to play about 5 sounds. So I kind of start, if you think about the piano and the different sounds that we're testing, I play kind of like a mid pitch, I jump to a low pitch, I jump out to the highest pitch, and then I fill in kind of the low mids. And so I'm sampling, because we never know when the baby's going to wake up. So we want to try to get as much information across the range as we can to understand the sounds that the baby's brain has access to. And these results will help us determine whether kids can access soft sounds and really, ideally, what sort of speech access they'll have. If we see a strong nerve response to soft and quiet sounds, we assume that in the tracing, if their nerve is reacting to quiet levels, we know that sound is reaching the brain in a typical way. So if there's risk factors for a later onset hearing loss, I would maybe recommend rechecking that child in 4 to 6 months, have them come back to do not maybe an ABR again, but switch into the behavioral testing and try to get babies, just monitor their outcomes and make sure their hearing hasn't changed. If there are no risk factors and the results were normal, I'm not usually recommending a recheck at that point. I would just encourage parents to return anytime if concerns come up down the road. I have a little auditory developmental milestones sheet. Since we moved to this new hospital, my forms got all kind of mixed up, and I'm trying to be better about talking about that and giving them that handout. On the flip side of the coin, if our ABR is demonstrating less neural activity to those quiet sounds or softer sounds, we would be confirming a hearing difference or a hearing loss. And, we try to use a visual graph. So the graph in the bottom corner where it says normal, slight, mild, moderate, we try to visually represent or demonstrate the responses from the ABR on the graph. And, really, I always wonder, we should really put together another study of parents, just asking like, how helpful is the audiogram? Do you understand what the audiogram means? There's been a lot of research into that kind of in the field in the last 5 to 10 years. And I don't always know that it's the best tool to use, but I do try to use it just because parents want to have some understanding of what these results mean and what they can access and maybe what they're missing. I also try to do like a simulation. I've got equipment that I can kind of enter the results into, and then we can listen to what that sounds like. So I think the stat is 90% of kids with hearing loss are born to hearing parents. So most of the parents that are in front of me are typically hearing and can't really wrap their head around what a mild hearing loss means. Like, what does that mean? Or a severe hearing loss, like, what does that mean? What does that sound like? So if I can use the audiogram and then do a simulation, usually parents are going to walk out of my office with a little bit of an understanding of where we're at. Hands and Voices has put together a resource packet, and that's the pictures that I've got on the screen there, that all of the materials that are in there have been designed by parents for parents. And so I try to use that guide. I'll mark stuff and write notes in there and then just kind of walk through it, explaining, what hearing loss is and what types of hearing loss there are and the severity. And I also have learned that not every parent is ready to talk about any of this stuff on day one, and just checking in, how are we feeling right now? Where are we at? We can come back to this. I can call you in a couple of days. We can email, whatever the preferred method to talk with me is. I've worked with enough parents over my time that I understand and I can see when we kind of shut down a little bit and that trauma starts to kick in. And I don't want to be going through all this stuff if we're just kind of shut down. So that's another reason I like these handouts, because parents can come back to it later and digest it as they're ready. And not everything has to be done right away. Next. So, because the ABR is not actually a measure of the child's hearing response through the entire pathway, again, we're just kind of measuring up to a certain point in the pathway. We use correction factors to convert like the ABR volume level into an equivalent hearing level that we would see. This is kind of getting into the weeds, but we use correction factors basically from the ABR to kind of estimate the baby's behavioral response. And Dr. James Hall is one of my audiology like superstars. He's a leading ABR expert in our field and has done a lot of research on the ABR. He's wrote multiple textbooks on it. And anyway, I use his correction factors because the equipment I use is the same that he's done all of the research on. So I just feel like that was the best when I started, and I found that those correction factors really are the best and most accurate for the equipment that we have. So we take like the ABR, like the wave tracings that I was showing you earlier, and we use those levels to convert into the responses that we would see on the audiogram. So it's more informational than anything. It's nothing too critical. Your audiologist knows how to do this. This is already happening behind the scenes. But if you hear things like correction factors, just remember that we talked about it. And yeah, then we put it on the audiogram and just use the visual to help understand what baby is hearing. Next. So just kind of going back to like the anatomy in the ear itself, the more severe hearing loss is, the harder it's going to be to provide really good quality and sound clarity through hearing aids. And if we kind of think back to the video that we watched before, the more severe the hearing loss, the less of the little cells there are. And so I think of severe hearing loss, if we go back to the piano analogy, severe hearing loss is like we're missing, I don't know how many keys there are on a piano, but if we took the whole piano, to me, severe hearing loss would be maybe like 10 keys on the whole piano that we have to work with and represent all of the sounds that are in the world. And so if we only have that many cells in the system, or we're, just thinking about that, if we're missing a lot of those cells, no matter what we do with the hearing aid, we're really not able to restore clarity and good quality. And so speech will still, even with the best hearing aids, the most high power hearing aids that we have, speech will not be represented clearly, and especially soft speech will not be represented clearly into the brain. We always recommend starting with hearing aids. That's always the first thing we're going to do if parents want to use spoken language and listening. But if we've got a severe hearing loss, that's probably, and we want to use spoken language and listening, we're probably going to have to think about cochlear implants down the road. We've got to start with a trial period anyway, make sure that we're doing everything we can to stimulate any of those little cells that are left in there. But ultimately, cochlear implants are probably going to be recommended for those more moderate and severe profound losses. When we're dealing with mild hearing loss, so this is like, can be like a real gray area. There's a lot of controversy, I think, in the field as a whole about mild hearing loss, and if we fit it or not. To fit it or not is a big question, depending on how mild it is and what the parents' goals are. I think every mild hearing loss is going to be very different. I feel like there's just always some level of, I don't want to say shaming, that's not the right word, but if a family is going from one center to another and they have a mild hearing loss, every audiologist might have a slightly different philosophy on the real slight and mild loss, if we're fitting it or not. So I always, just want to highlight that there's a lot of reasons and a lot of decisions that go into fitting a mild hearing loss. There's guidelines, there's all these things that we think about. And I talk through all of those recommendations with the families, and we really monitor strongly. If we decide not to amplify a slight mild hearing loss, I've got a lot of people on my team that are watching the development and making sure that we've got access. And I always tell parents that the plan may change depending on what we're seeing in this next 6 months, or in a year or 5 years or whatever. If we start to see delays, my plan might change, or my recommendations might change. So slight mild hearing loss, it can be a little more fluid, maybe a little bit more options or choices, the more severe the hearing loss is, hearing aids or implants really are critical. Next. Next slide is just kind of highlighting or showing what some of the different audiograms or hearing graphs look like. I didn't know how long you wanted me to talk. I mean, audiograms are like, I could have a whole talk just on an audiogram. But hopefully like the colors help. On the one on the left, we've got like the top of the graph is normal hearing, and then each level down is like a different severity. We use degrees, so mild, moderate, moderately severe, severe, and profound are kind of the ranges. There's a lot of work, again, being done looking at what's meaningful to a family. If we use kind of like a color-coded system, does that make it a little bit easier to understand? So that hearing loss grades is just one way to look at it. I wanted to just put the two different hearing losses up here too, because I think like a lot of times people think hearing is like black and white, like you're either hearing or you're not. And there's just like this whole entire gray area. And most of our kids are like gray. They're not like typical, or they're not severe. They're like in the middle. And so the graph on the left really does a good job of highlighting that the X's and O's are the O's are the right ear, the X's are the left ear. They start off in the real low pitches, the bass sounds, they're up in the normal range. So they can hear real low pitch sounds completely fine. If we think back to the video, it's like the tuba sound, like that sound is normal. But then as we come like into the mid pitches and down into the high pitches, those levels slope down. And so this kid, if this is a kid, this isn't my test, but this particular patient would have very difficult time hearing a flute or a piccolo. Like that sound is going to be pretty much non-existent. Like it would have to be amplified quite a bit in order to hear it with that particular hearing level. So audiograms come in all different configurations and different, everybody's looks a little bit different. And the one on the right is just showing a severe to profound loss. And so again, the red circles are the right ear, the blue X's are the left ear. They're down in that severe to profound range. And so just slightly different. Next. I just wanted to kind of briefly go through some of the other terms that you might hear if your child's been diagnosed with a hearing loss. So we say unilateral or bilateral. If the hearing loss is in one ear, it's unilateral. If both ears is bilateral. Prelingual is just meaning that the hearing loss occurred before our child learned to talk, prelingual, or after a person has learned to talk, so postlingual. Symmetric or asymmetric, like thinking back to the graph on the last page, on the left where it was kind of sloping down, we would say that's symmetrical. Both ears were almost identical. They tracked right alongside of each other. Asymmetry or asymmetric is, maybe one ear is up at the range of normal and then the other ear is down in the moderate range or whatever. Just means that they're different. Progressive can happen. We have lots of kids that are progressive, and we might start in the mild range and then end in the severe to profound range or wherever. So we always are thinking about progression. Not too typical in kids, but we can have sudden hearing losses that happen. We see it a lot in our adult population in the clinic. I had 2 today. So patients can acquire a sudden hearing loss and hearing can drop out. Lots of different reasons why. Fluctuating or stable. So fluctuating would be like it just kind of changes over time. So usually when we think of fluctuating hearing loss, we're thinking of like ear infections, right? So you might have one level of hearing when there's no ear infection, but then all of a sudden we have a bunch of fluid develop behind the eardrums and hearing changes. And then the fluid goes away, we get healthier and all of the congestion is gone, and then it comes up and it's just changing over time. Stable obviously would just mean it's stayed at the same level. And then congenital is just meaning that the hearing loss is present at birth versus something that was maybe acquired later. We have trauma that can sever the hearing nerves. Fractures can hurt the temporal bone and cause some damage anatomically. That's kind of the main one. I'm trying to think about this. Sudden hearing losses can be acquired from autoimmune conditions, all sorts of different syndromes, maybe where it would progress and come on later. Next. So, I always try to like be just really present in the moment, you know, when I'm saying something like your child has, you know, a hearing loss, because most parents are just like, well, okay, now what? Like, what does that mean? And what it means to me is that this is like the first step, like this is just the beginning. We're confirming that, you know, there is a difference in the way the sound is being processed, and we're going to be with you every step of the way. You know, I do my best to be very available, to counsel, provide education, support, connect our parents with other parents and the right professionals, the right team members. I think the first couple of months are just a whirlwind, and I wish I could make it be easier, and I wish I could take on some of the load, but there's just a lot to get through because we really want to do everything. Like I said, it's a huge responsibility that we're kind of tasked with, and we just really want to make sure that we're doing everything we can to set your child up to have the best outcome as possible. And the more work we put in the beginning, the more it will pay off in the long run. So we are going to talk a lot about different referrals. Medically, we're making sure that we're not missing any other organ involvement and any other systems that might be involved. We want to get you with the right people to develop speech language, just not even speech, just language. We're going to follow up and follow up and follow up a lot more because we want to make sure that we're accurate and that my test is showing, this is actual, this is legit, this is what it is. A lot of times I'll have parents come back for another test to just confirm what we're seeing. That gives parents time to process things too, come back with questions. Just maybe, seeing it twice just gives them a little more peace of mind that this is real. We try to get our kids in the sound room and in doing behavioral testing as soon as possible. We're going to talk about communication options. We're going to talk about equipment. There's a lot of stuff to get through. And again, we try to get through it as parents are ready and at the right pace. Next. I'm kind of talking a lot, so I'm going to just kind of breeze through this because I want to get through. I've got about 3 or 4 slides left. So causes, risk factors, characteristics. There's just a lot of different reasons why these hearing losses might be present. And again, it's really critical that we are checking all these other things out, because if something else is going on in the baby's body, we really, obviously, and you as a parent, you want to know that. I've had kids that are missing kidneys. I've had kids that have severe visual impairments that might come on later in their life. And, we need to know that so that we're setting up the child not only for doing everything we can to access hearing, but that we're setting the child up for good success, navigating their space if they have low vision. So we're really thinking about kind of the whole child at this point and making sure we're making the right referrals to look at all these medical things. We might talk about genetic screening and genetic testing. A lot of our kids, it's a genetic, each parent is carrying a specific gene, and it just so happens that you put those 2 parents together and we have a genetic difference. And so it results in hearing loss. But moms being exposed to different types of viruses. I always think of the acronym TORCH. The toxoplasmosis is something that cats can carry. That just has always stuck with me. I always just ask about that if we're diagnosing hearing loss, if maybe that was something that mom was exposed to. A lot of different types of viruses, rubella, CMV, the herpes virus, HSV. There can be a lot of other things baby was exposed to perinatally. So maybe we had a traumatic birth, or we were in the NICU for 5 months and we were exposed to a lot of different antibiotics, really harsh in the ways, really unnatural in the ways. Maybe we didn't have a lot of oxygen at birth. Maybe we had nuchal cord, and the umbilical cord was wrapped around the neck or something. Lots of different reasons. So we try to get through and try to have an etiology. Etiology and knowing why we have the hearing loss can help us plan for the future and have an expectation of maybe where it's going, if it's going to progress or not. And that, again, we're just thinking through all the other organs. Next. Just some data from the most recent CDC information that I could find with North Dakota specifically, and thank you, the EHDI crew, for doing all you can to always get us the right numbers and track every single baby that's born. It's just such a big undertaking. So in 2021, which is the most recent data I could find, and I'm sorry because I didn't ask anybody at EHDI, I just Googled it, but we had 15 babies born in 2021 that were reported back into Oz. So that could mean some babies were born, but not, or some babies were had hearing loss, but maybe not necessarily entered into the system. So we had 15 babies in 2021, and that would mean our prevalence per 1,000 births is 1.3. A lot of people will say anywhere from 1 to 3 babies per 1,000 births. So that's pretty much tracking right with the national averages. Next. I just wanted to throw in a couple pictures of like, you know, again, I said, if we are diagnosing a hearing loss, we want to use spoken language and listening. We're going to start with hearing aids. So these are just pictures. The middle there's some hearing aids that we work with for kids. They can be fun. They can be colorful like this. They don't have to be. Some parents want to blend, and that's just fine too. I just want kids to wear them. So whatever that means for the family, especially when they're babies, parents are in control of that. So if they want it to blend, that's just fine. Or if they want it to be fun, that's great too. We've got the hearing aid, which would connect to the ear mold, which is on the bottom level there. The ear molds are going to look different at different ages, and based on the level of hearing loss, you need a bigger mold if you've got more hearing loss to kind of seal in everything. We also use a full mold when babies are under 6 months because their ear canals or ears are just so tiny. That's the only way that it's going to stay on and in their ear. Maybe they have a more mild hearing loss when they get a little bigger. We can go to a different style that's maybe a little smaller, like the blue molds with that thinner tube. Usually the hearing aids will come with a little care kit, which is the little backpack there, and it's got some tools in it for parents to listen to the hearing aids and take care of the hearing aids, make sure they're working well. The way our account is set up, we get a free microphone with every hearing aid that we are getting for kids. So up in the right-hand corner, that tiny little microphone is a mic that you would wear as the parent. It's capturing your voice and then streaming it right into your baby's ears. And I think especially for our maybe our later onset, or we don't really know when hearing loss started, but we're maybe acquiring this kid at I'm acquiring the kid at age 2, and maybe we're already a little bit language delayed. That mic is going to be the best way that we can just bombard baby with words and build those little networks and build up the hearing system. So I really, really strongly recommend that we wear those all the time, and that you are just constantly talking to your baby, and building vocabulary. The hearing aids now all connect to apps. So that's what the phone is. I love this app. It uses, or it gives you access to like volume control. So if you walk in somewhere and you just see your baby like kind of starting, or your child just getting a little uncomfortable or whatever, you can pull out the app and just bring the volume down a touch. You can reach out to me from the app. So we can actually do some remote stuff, which I love because lots of our kids are 3 hours away. So it's really just been a nice tool to do some remote stuff. Up in the left-hand corner is Rogers Systems. So it's just a little more fancy and sophisticated version of the microphone that's in the other side of the picture. So lots of different things that you might see, or you might acquire, you might get from us as the audiologists. Next, I just put some links in here. So hopefully this PowerPoint will be available. I don't know, I guess if it's available or not, but I just put a link in there to like all the pediatric audiologists in North Dakota, Hands and Voices website, the EHDI website. EHDI Pals is like one of my favorite websites. I use it all the time because we have so many transient families and families that are moving in and out with the Air Force Base and the oil field and all the things. So EHDI Pals, I can pull up, or your parents can pull up, and wherever you're moving, we can just put your zip code in and then find all of the pediatric audiologists that would be in that place. And so we can actually just like reach out ahead of time, establish care, and make sure it's going to be a good fit. So I love that. Hearing First is one of the best resources available. I love their stuff. Both of these pictures are from their website. They give so many free resources to us as professionals, trainings, all sorts of really good stuff, but also for you as parents. Just tips and strategies. What is going to make listening easier for my child? How do we think about decreasing noise in the home to make speech more accessible? How do we talk to our babies? I said we want to just keep talking to them, but like sometimes it's like, what do I say? Or how do I talk to them? So they give you full examples and scripts, and not scripts, but just tips and resources. So check that website. Success for Kids with Hearing Loss is another one of my favorite resources. There's many, many out there. These are just a few. Next. So last couple slides here. Just again, importance of early detection and intervention. The ABR is just the most critical piece to the puzzle to identify hearing levels. And so we can make the most informed decisions about where we go next. If we don't do 1 through 6 and your child has a profound hearing loss and doesn't hear, if we wait until a child is 6 years old, all of that neural development window has already kind of closed. And so they will, if we get an implant later, maybe, then we think, oh, we can put an implant in when they're ready to choose. That is one method, or that's one way to think about it. But from our perspective, that doesn't really give you the choice or your child the choice to pursue spoken language, because those centers have changed. And so the outcomes just aren't going to be the same as if we thought about that sooner. So, thinking through just the model of 1 through 6, it's really important. If you want to have the best and informed decisions to make the best choices for you, you got to know what your hearing levels are. So it's just the first step, and establishing a lifelong journey with our patients. I've been with some of my patients for 13 years now, and just watching the kids grow is one of the best parts. It's the most rewarding part. Seeing all the work the families do in the beginning, and then seeing our kids just thrive there's nothing better. So, like I said, I try to be cognizant and thoughtful of where parents are and meeting families where they are in their journey, and providing what I can provide to help along the way. I think that's everything. My contact is on there. Reach out, like I said, anytime. I'm happy to help.
That was excellent, Trisha. I even, I feel like a veteran, and I learned a couple new things today.
Well, good.
Yeah. So that was
Good.
great. I really want to back up your comment about the kind of the post-traumatic area and families tune out. We were not given any resources at all. I mean, so this was years ago, and I distinctly remember them, because both the audiologist and the ENT was in the room with us, and my brain shut off. I didn't hear a word they were saying. It was just like everything shut down. It was completely, I've never experienced anything like that. So yeah, thanks for bringing that up. I thought that was really great. Does anybody have any questions at all? Sue, Kathy? This was awesome.
Yeah,
Thank
I
you.
agree. Thank you so much. I feel like I've been around a lot too, and I learned lots of new stuff. And I too had a late diagnosed kiddo.
Mm.
And we didn't have a lot of those early on supports. So the sooner the better. I'm here to say it too. So
Yeah, for
thank you
sure.
so much. It was very interesting. You're very knowledgeable. I appreciate your visits. Are you doing this for us?
Yeah, it's my pleasure. Anytime.
Yeah.
Sue, I just saw your comment 20 and 2022. I'm glad we're finding more, if
Yeah.
that's what that suggests.
Mm-hmm. And Lindsay, thanks for joining us tonight.
Yes, thank you.
All right. If nobody has any questions, we're going to end for the night. So thank you, everyone.
Thank you.